right, and so this will be closing the session for today, and we'll have a discussion about it afterwards. We've actually addressed this quite a bit about whether we think we're doing enough, and I think you've seen data that I've showed that I will show again, and data that Iona showed and that Connie showed that we probably aren't doing enough in terms of even where we've set our targets at the moment. We're probably not, effectively reaching those targets. But what I really am going to start to address a little bit more is do we have the right targets, and should we be thinking about even different targets than what was set in the most recent guidelines, the ACC and AHA. What I'm going to show is I think is already been said by others, maybe a little bit provocative, but I think it's where the data lies, and then we can figure out pragmatically how to get there. So as I alluded to, I've shown you this before. Connie showed you the EuroAspire 4 data. The question is, have we actually optimized lipid control? Are we there yet? I showed you this data from 2017, looking at patients who've had ACS or a coronary event, where the targets were at that time an LDL of less than 70 or 1.8 millimoles per liter, and that only a third of patients were actually getting there at those targets at the time of hospitalization, and at the time of discharge, only 50% were going out on high-intensity statins. So, this is pre the sort of escalation in therapy that's been requested by the most recent guidelines, or the escalation in targets. But nevertheless, we really weren't in the real world achieving those targets. And we've talked about many times over now that the targets have moved. That now in patients, instead of being 70 who are very high risk, we're shooting for 55. And then those very high risk individuals, we're now shooting for 40 milligrams or 1 millimole per liter. And so I think that this is a good step. You guys have probably all heard what my bias is in terms of moving in the right direction for what we should be targeting. But I think that there are some arguments out there to say, well, let's step back and say, what is the optimal LDL? And is there additional efficacy to be had for driving LDL very low? And are there any particular safety concerns for driving LDL very low? And so that's what I'm going to try to address over the next 20 minutes or so. And so this is where the answer lies for that knowledge question. So if we look at, this was a publication, which is sort of a little bit older now, 2004, but looked at average lipid levels, total cholesterol in various populations to just sort of see where do people naturally fall. And so in the hunter-gatherer populations, so those that are listed there, the total cholesterol is on the order of 100 and 140. So generally very low, and there's really not been documentation of much atherosclerotic disease in this population, even out into their 70s and 80s. Primates, also very low. Mammals, similarly low. And then adult Americans, 208. And so this is 2004, but just to say that we're, probably at least twice as much as it, seems to be necessary. And so if you were to translate this into LDL as opposed to total cholesterol, that hunter-gatherer population is somewhere in the order of 35 to 70 milligrams per deciliter. So some have used this to suggest that might be an optimal target, and that this patient population who, with their sort of non-Western lifestyle, achieve these low levels, don't seem, live to older age without atherosclerotic cardiovascular disease. So that's one potential avenue for explaining or coming up with what is an optimal LDL. Now, I've shown this before, which is to say that we've also done this in a trial setting, over and over again now over the last 20 to 25 years, where we just keep pushing the LDL lower. And the answer is consistent, that the lower we go, the better, right? But what about down to those extreme levels? And now we are fortunate to have a lot of data. We've amassed quite a bit of data where we can speak to safety and efficacy about very low LDL levels. One that I'm showing here is looking at achieved LDL in the Prove It trial. So as the sort of combination of either Prava 40 or Torva 80, and there were a number of patients who got to less than 40 milligrams per deciliter with their LDL. And in that setting, you see that there is a non-significant but a trend towards increasing benefit for lower LDL levels achieved. And so this was somewhat suggestive of, well, maybe we should even be driving it lower. And I'm not going to show the safety data here. I'll show it for other studies, but there was no safety signal that came out in that population who had the lowest achieved LDL. The next piece of information we have is from Improve It, which, as you know, was a post-ACS population, about 18,000 patients randomized to a background of simvastatin or simvastatin plus ezetimibe, followed for a very long duration, 6 years, and much of the data it was on median 6 years. Many were longer than 6 years. We accumulated a huge number of events, more than 5,000 events. And what you know about this is that, in fact, we drove LDLs from just with a background of simvastatin down to 70, and plus ezetimibe down to about 54 milligrams per deciliter. So this is really the lowest that at the time that any of the studies had gone. And so really getting people down to fairly low levels. And with that, there was about a 6% reduction in cardiovascular and major adverse cardiovascular events, which was proportionate with the amount of LDL reduction, which was about 15 milligrams per deciliter. So it was as expected, modest, but modest because, one, the LDLs were so low and because the delta in LDL was also relatively small. But so there is the data for the primary results for Improve It. But what I think is interesting is to say also, what about those, what do we see for achieved LDL? And do we have any particular concerns about safety in that population when we really drive LDL low? So what you can see is at 1 month, there is a significant proportion of the population who either achieved an LDL less than 30, or 0.8 millimoles per liter, or less than 50, so less than 1.3 millimoles per liter. And when we then we also divided the bins into 50 to 70 and 70 to 100 and say, well, let's look at these various groups of patients and how they fared. So it was about 6% with the lowest, and then a third, and a quarter into the highest area. And looking at safety. So there were a number of different concerns about, say, for example, if you really drive LDLs low, are there more muscle events? And the answer was no. There was no difference when you look at those who had the lowest achieved LDL versus the highest achieved LDL. AEs leading to discontinuation, again, no significant difference there. Any difference in neurocognition? This was one of these really big questions where everybody said, well, doesn't the brain need some lipid around in order to sort of maintain function? And the answer was, in this study, no, there wasn't any difference across those achieved LDL ranges. Another thing, which I'll tackle again later, along with the neurocognition, is the risk of is hemorrhagic stroke. Is there something about driving down the LDL to very low levels that makes you more prone? Do you have more vascular fragility and higher rates of hemorrhagic stroke? And what you can see is that, generally speaking here, the rates of hemorrhagic stroke in this patient population was extremely, extremely low, and there didn't seem to be any correlation or any association with achieved LDL. So that was pretty reassuring. And then finally, the efficacy piece, which everybody cares about, is when you then look at these patients and say, what about those who achieved less than 50 versus those who achieved more than 50? There was a significant benefit in those patients who were lower. And so it seems to suggest that this curve, this was introduced to you in the very, very first talk by Dr. Packard. Is there a U-shaped curve or is there a J-shaped curve? And for Improve It, we didn't see that. And when you take it down to the very low levels. Now, another example is Fourier. I told you there was a little bit of difference between the PCSK9 inhibitor trials, Odyssey, Outcomes, and Fourier. Fourier, there was no restriction on letting people go very low with their LDL. And so this is sort of a good population then to say, well, what's the safety and efficacy of driving LDL very, very low? As you know, 27,000 patients who had either prior MI, prior stroke, symptomatic PAD with an LDL greater than 70 or 1.8 millimoles, or non-HDL greater than 100 or 2.6 millimoles, followed on median for 2.2 years. You've seen 60% reduction. But notably, what you see is, again, there are lots of patients who fall, in the treatment arm with evolocumab down to 0.8 millimoles per liter, and a quarter of them down to less than 0.5 millimoles per liter. And again, you know about the outcome. So that is to say that people got very low, and a large proportion of patients, and I'll talk to you about the sort of achieved levels, got extremely low in kind of less than 20 range for their milligram per deciliter for their LDL. Now, the Fourier investigators built in a sub-study, a neurocognitive sub-study to Fourier called Ebbinghaus. It was in about 1,200 individuals followed for the duration of the study, and they tested through various different means neurocognition at baseline, 6 months, and then every year. And the specifics of how it was done are, again, there were many tests to sort of reinforce the findings, but basically what you see is placebo shown here in one of these cognitive tests, and evolocumab here at baseline. There's no difference, as you would expect in a randomized trial, that at baseline the population should look the same. And what you see is at the end of follow-up, which was on median about 19 months, there was no difference within the arms and no difference between the arms. So there really wasn't any concern in terms of development of any neurocognitive issues. They specifically tested for about a non-inferiority boundary that was around 20% of the standard deviation, and you can see they're very far off of that. So that was clearly non-inferior in terms of neurocognitive. So I think the take-home is to say that in the time frame that was studied, there were no concerns. It's studied in a sort of very rigorous way within the Fourier trial. Now, I said I would also come back to hemorrhagic stroke. So this is a story which is interesting and has sort of evolved over time. There was a study, the Sparkle trial, which was published in 2006, which looked at about 4,000 patients who'd had a history of stroke or TIA, and then treated them, randomized them to either placebo or atorvastatin. And there was a significant 16% reduction in all stroke in that patient population. So a statin was good to reduce recurrent stroke events in this patient population. However, what they did note is while infrequent, only 33 versus 55 events, there was an excess of hemorrhagic stroke, which ended up being significant in this study. And so that raised concerns. Well, is there something about lowering LDL that drives hemorrhagic stroke? They did some subsequent analyses, and I'm showing one right here, where they said, well, what are the drivers of her hemorrhagic stroke in this patient population? And what they found was that the independent drivers of stroke were the fact that somebody had had a prior hemorrhagic stroke. That was a high, sort of high risk situation. Age was a driver. Older age was a driver of hemorrhagic stroke, and in fact, being a man was also a driver of hemorrhagic stroke. But what was not was achieved LDL. So LDL was not, an independent risk factor for having hemorrhagic stroke in this patient population, which I think was interesting and sort of enlightening in terms of the concerns. And now we look beyond Sparkle and we say, what about the totality of data that we have, and are we concerned about hemorrhagic stroke in this patient population? So CTT meta-analysis shown here are basically the data for about 150,000 patients treated with, more or less statin, or, more or less, or statin or no statin. And what you see is in this very large database, there was no significant increased risk of hemorrhagic stroke there. Now, I will acknowledge that the hazard ratio is on the wrong side of 1, but in this enormous database, what you see is that the absolute risk here is very, very, very low, 0.1 to 0.3%. And it doesn't seem to be, at least there's not a significant excess of hemorrhagic stroke. Now, this is an analysis from Mark Sabatine looking at non-statin trials and specifically focusing on the patient population who had started off with a low LDL, so an LDL of less than 1.8 or 70 milligrams per deciliter, and then saying, was there an excess of hemorrhagic stroke in those individuals who started low, and then you drove them to even lower levels. And this is the overall here. So again, no significant excess in the non-statin data either. Granted, it is a little bit on the wrong side of 1, but again, it's not significant. So I think the data is accumulating and for me, fairly convincing that really driving LDLs down low is not concerning for hemorrhagic stroke. That's my take. So now I'm going to present two clinical situations that you may come across in your clinic and thinking about how to handle these patients. The first is that patient who I see who in fact actually has a pretty low LDL at the start, and do I feel comfortable pushing it lower? And then secondly is that person who I initiate aggressive lipid-lowering therapy on, and they actually get very low with their levels, and do I need to, as we've talked about in the past, do I need to think about backtracking a little bit and sort of de-escalating therapy? Is there any concerns and any reason why we need to de-escalate therapy? So for the first scenario, in Fourier, even though the entry criteria were an LDL of greater than 70 milligrams, there was another entry criteria which could be that the non-HDL was greater than 100 milligrams. So you could have some people, say for example, who had high triglycerides, who had an LDL that was less than 70, but a non-HDL that was higher than 100. And so there were 2,000 patients who came in with an LDL less than 70 into the trial as their baseline LDL. In those patients, so those who had an LDL less than 1.8 or 70 milligrams at baseline, you can see that with evolocumab, they got similar reductions to what we saw with the overall population on the order of 60%, here 66%, but let's say just on par with what we've seen. And the median achieved is 0.5 millimoles, so about 20 milligrams per deciliter, and 25% of them were even less than around 10 milligrams, 12 milligrams per deciliter. So really very low levels. I think it might have been Dr. Mock who presented a case of somebody that he drove down to 15 and then some other provider peeled back the statin. But this is the example. This is that case, right? That is that patient who's been put on a PCSK9 inhibitor and now has very low LDL. When we look at outcomes, in this patient population, we look at them based on those who start with a low level versus those who start with a high level for the primary endpoint. And what you see is there's really consistency of effect in terms of relative risk reduction. So you still get the same benefit, even if you start lower. And so again, there's formally no interaction there, no heterogeneity. And the same is true for the key secondary endpoint of MACE, that there is consistency of benefit regardless of where you start. And so if you start at a low level, you still get the benefit of being driven even lower. And this is just the KM curve to sort of show you that in those patients who, had a low level to start with on placebo versus evolocumab, that over time you certainly do accrue the benefit. There is some delay in onset of action. The curves wiggle a little bit here because the population is a bit smaller, but anyway, it's fairly convincing that there is benefit in those populations. Now, a huge question is safety. Are we worried about safety in these groups? And the answer in this analysis is no. So there was no excess of any adverse events, no excess of serious adverse events. There is, and we have seen this repeatedly, an excess of injection site reactions, no excess of neurocognitive concerns either. And so then to take that on, Mark Sabatine did an analysis where he said, well, let's look at basically all the trials where we have patients who've started out at a very low level, who started out less than 70 milligrams per deciliter, and see about the safety. And so they pulled out the CTT patients who started out with a lower level. They pulled out the Fourier ones, which I've just presented to you. Improve it, everybody started pretty much below that. And then said, let's meta-analyze this and see what kind of benefit we get. And again, it's consistent with what we've seen historically for, the magnitude of LDL reduction, you still see the same cardiovascular benefit. So I think the answer is the benefit's there. I think the safety is honestly, I'll show you more data, but I think the safety profile is good. And so now I said the next clinical scenario, so you see that patient who has a low LDL, this is your patient who is very high risk. That last one is somebody who's very high risk. They're at 70. Now the new ASC guidelines say to take it down to 55. How comfortable do I feel doing that? And I think that's the data that supports you can feel comfortable to do that. Now we have another scenario, which is looking at outcomes by achieved LDL. So what we did is we basically said at 4 weeks, let's look at everybody's LDL, and we group patients based on their achieved LDL, similar to what was done for the analysis that I showed you for both Prove It and Improve It, and said, okay, let's look at those with extremely low LDLs, and then those in still very low, less than 50, 50 to 70, 70 to 100, and then greater than 100. And we actually pooled the treatment groups because it's really it was more about the achieved value than it was about the treatment. Now, as you can imagine, most of the people in this range down here are ones who've been treated with evolocumab, and most of these are ones that were not treated with evolocumab. But nevertheless, we pulled the data and then said, what does their LDL look like over time? And so these are those patients who got to very low levels, less than 20 milligrams per deciliter, consistent over the duration of follow-up, which again was a median of 2.2 years. And then what we see is that this curve is, again, this is for MACE, the key secondary endpoint, it's linear, right? And this is down to now extremely low levels, less than 20 milligrams per deciliter. And if you want to kind of know what the specific hazard ratios are, they're shown here for those different groups. But this is an answer to this reiterates what Dr. Packard said in his first couple slides, is it's not J-shaped, right? It's not U-shaped. It is linear all the way down to these low levels. Now, again, safety. So big concern. Obviously, people are worried about this. When we look, apologize for the rainbow, but it certainly, I think, gets the point across, that there's no excess of serious adverse events, no excess of AEs that led to discontinuation, no excess in the time duration that we studied in new onset diabetes, no excess in neurocognitive issues, no excess in hemorrhagic stroke. And so that was pretty reassuring across the board in terms of the safety profile. One last bit, I think, it's a little bit harder to show the data about very low levels with Odyssey because they sort of titrated to that range of kind of 35 or 25 to 50. But nevertheless, there were a lot of alirocumab studies, and Kosh Ray did an analysis where he pooled all of these studies together and said, let's look at people who have achieved very low levels with alirocumab and see what their safety and efficacy profile looks like. So in placebo-controlled studies, in ezetimibe control studies, and the results are basically these curves look the same, the Fourier curves and then the alirocumab curves, where again you just see this sort of benefit, even down to very low levels of LDL, which is certainly reassuring. So where does that leave us? You've seen this before, you know what my bias is, but I think improve it, reinforce that even lower is even better. And I think that the Fourier and Odyssey data, as well as what Kosh presented in the last data I just showed with alirocumab, that lowest is best. And so this I think is sort of fun to see that there was Brown and Goldstein back in 1985 discussed in a Nobel lecture about what might be the optimal LDL. And their thought is that maybe getting down to a LDL level of 25 milligrams per deciliter would be sufficient to nourish body cells with cholesterol, which is roughly 1/5 of what we see in Western societies. And so they put a plug in for 25 milligrams per deciliter. I think you've heard now multiple times that some of the panelists think, well, there's no reason to have any cholesterol per se, and you could probably drive that down to zero. And I think that then the next step is, I think we've amassed a huge amount of data over 25 years to say that it is both safe and efficacious to drive down lipids, to be aggressive with lipid control. And this has also been discussed previously by the group, but I think there's also mounting data, much of it from Brian Ferentz, to kind of say, well, let's look at these patients who have, sort of lifelong lipid control because of their genetic profile, and what sort of incredibly robust, reductions they see, or relative, reductions they see from having this lifelong lowering of LDL. And so you saw another analysis that Brian did, I think Dr. Packard showed that, and then this is one that was just recently published, where he said, okay, let's look at the sort of scenario of somebody who has a genetic risk profile that results in a 1 millimole per liter lower LDL-C over the duration of life, and a 10 milligram mercury or millimeter of mercury lower in blood pressure. And you have, and what is that, 78% reduction over a lifespan in terms of cardiovascular events, which I think the argument then there is to say, well, we've been focusing, and I am guilty of this, focusing on high-risk populations and saying that's where you really get the robust absolute risk reductions and the number needed to treat. But I honestly think we should start thinking more globally, and we should be thinking, about what about minimizing that cumulative LDL exposure, like those lucky individuals who have some, sort of favorable genetic risk profile that allows them to see lower LDL levels over the course of their life, which pushes out their risk of having an event until some much later point in life. So this would be, for example, this curve that I just drew might be our hunter-gatherer, and maybe that's what we should be aspiring to. And you've heard the group talking about dietary ways to get there. So I think that's probably where we're going next. And so in conclusion, I think the data is clear. Even lower is even better. And I think that relationship is consistent down to very low levels. And that relationship for benefit for cardiovascular protection is consistent to very low levels for LDL. I say mounting evidence to support the safety, and the reason why I say that is that there was a caveat made earlier, which I agree with, which is for the Fourier and alirocumab data, we have 2 to 3 years of follow-up in terms of showing safety. I did show you the Improve It, which was out to 6 to 7 years, so a little bit longer duration. But I can appreciate that there may be some counter to that, which is what happens if you give lifelong therapy. And I'd say maybe the genetics will support us there. And then finally, that there should be a goal now of thinking about achieving low levels earlier to maximize cardiovascular benefit and to minimize the risk of future cardiovascular events. And so with that, I will conclude. Thank you very much. So what is the mean cholesterol of modern adult Americans? Modern being in 2004. Good. Nice work. 75% of you got the answer right. That's great. And I wouldn't have expected, without having seen the slide, to know that.